Prevention and Intervention of Delirium in Hospitalized Older Adults with Allison Ryan, Hannah Tomlinson, and Brittany Whitehead. On the agenda are what is hospital delirium, identifying delirium, the risk factors, assessments and screenings, and intervention. Key terms are comorbidity, polypharmacy, predisposing factors, and precipitating factors. Comorbidity are presenting with 2 or more illnesses, and frequently those are chronic illnesses. Polypharmacy is many medicines, and that could be more than 2 or greater than 5. And then predisposing factors, the risk factors present at baseline, which increase the patient's vulnerability to delirium. And the precipitating factors would be the factors present in the acute setting that trigger the delirium. Delirium is an acute condition with a change in cognition and attention. It is a neuropsychiatric syndrome with altered consciousness, cognitive impairment, and inattention that fluctuates in severity. It can have a prodromal phase, which is characterized with agitation and anxiety. And while it's often unrecognized and untreated, it's often begins early on in the hospitalization. Interventions to identify, prevent, and treat delirium should be implemented early in the patient's hospitalization. There are different types of delirium. There's a hypoactive state, hyperactive or hyperalert state, and then a mixed presentation, which is hypo and hyperactive. In the hypoactive state, there's often lethargy, confusion, hallucinations, possible delusions, and it's more of the patients in their inner thoughts, and they often have abnormal thoughts. And then in the hypoalert, the environmental stimuli are overstimulating, and it creates an agitation. The patient could be pulling on tubes. They might be combative or have physical aggression. The third type with the mixed presentation is both hypoactive and hyperactive, and it can have daytime drowsiness and then at nighttime and insomnia and agitation. There's some risk associated with these delirium types. The hypoactive patient who is often lethargic is at risk for dehydration and aspiration pneumonia, and their impaired mobility puts them at risk for pressure ulcers. With agitated in the hyperactive state, patients frequently have a risk for harming themselves or others, and that often puts them at a need for pharmacological treatment.
Identifying delirium. We are going to be discussing risk factors such as predisposing factors and precipitating factors, illness symptoms, and environmental links. This will be followed in the coming slides.
Predisposing risk factors are pre-existing cognitive impairment, which could be dementia or other types of impairment. And people with dementia in the hospital have a higher rate of delirium. There's also functional impairment, polypharmacy. As we age, there's physiological age changes, and this affects the pharmacokinetics and the pharmacodynamics of medications, which means that the older patient with many medications might have more frequent drug interactions or drug-and-drug interactions, and then also changes in absorption. If a patient has underlying health problems, that's a predisposing risk factor, and also having a major elective surgery, and which could be a hip fracture or cardiac. Hip fracture isn't always elective, but those surgeries frequently have increased opportunities for delirium. Other predisposing risk factors are fluid and electrolyte imbalance, including dehydration and hyponatremia and hypernatremia, malnutrition, hearing loss or hard of hearing, and vision loss, and then also chronic pain.
Precipitating risk factors. As discussed earlier in our key terms, these are risk factors present in acute settings triggering delirium. ICU admissions incur an 80% incident rate of triggering delirium, along with urinary catheterization, electrolyte imbalances, glucose imbalances, acute kidney or liver failure, acute hypoxia, immobility, and, of course, absence of hearing aid or glasses because the patient is not able to interpret things going on around them. Continuing with precipitating risk factors: anesthesia and sedation, restraints, inappropriate medications such as drug and drug interactions, unmanaged or uncontrolled pain, medications newly started or recently discontinued medications. Use of drugs that alter cognition are known to cause delirium, such as benzodiazepines and other sedatives, hypnotics, or analgesics, and medications with anticholinergic effects. A higher rate of delirium is found in patients with previous cognitive impairment or dementia.
Common medications that cause or worsen confusion. In the Gerontological Nursing by Mock on page 435, there's a table that includes medications and also gives some examples. Of note are anticholinergics, and those are limiting to acetylcholine, and acetylcholine is an important neurotransmitter in the brain that improves memory and affects your memory functioning. So when you limit it with an anticholinergic, you are causing memory problems, which will cause delirium. Then analgesics are opiates, which are often given for acute pain, especially with surgeries. And antipsychotics sometimes can be used for treatment, but also can cause or worsen confusion. So there should be care there. And benzodiazepines are not indicated for delirium. They cause and worsen confusion, but they are used for alcohol withdrawal and the delirium that is associated with that condition.
For many serious illnesses, such as poor pain control, fecal impaction, infection like urinary, respiratory, or skin, hypo or hyperglycemia, fluid and electrolyte imbalances, hypoxia, or head trauma, and repercussions from medication use, can be seen with only delirium as the presenting symptom. Many environmental factors can impact delirium. Most of these environmental factors are modifiable, such as a crowded hospital room, lack of natural light, and lack of windows or view to the outside world. In the following slides, you'll see how simple interventions can help prevent these.
Next, we will be uncovering some key points for nurses to consider when assessing for delirium in older patients. Upon entering a patient's room for an initial assessment, we want to ensure that we are checking the room for any environmental triggers, which we previously learned are precipitating factors. We want to become familiar with an older adult's past medical history before assuming care so that we are prepared for an impending episode of delirium. As we discussed earlier, we now understand that an extensive past medical history, especially a history including chronic illnesses, is known as a predisposing factor. We will discuss the mindset nurses should have when entering into an initial nursing assessment and a couple of standardized delirium assessment tools that will be useful in identifying as well as preventing potential episodes of delirium. The standardized assessment tools we will be covering are the Geriatric Risk Assessment Med Guide, also known as GRAM, the Informant Questionnaire on Cognitive Decline in the Elderly short form, and the CATS Index of Independence and Basic Activities of Daily Living. Lastly, we will discuss some ways that we can modify risk factors to mitigate the delirium. As has been already discussed, delirium is often missed after an older patient has been admitted because there are times when symptoms can be subtle and the patient is in the prodromal phase, or the assumption is made that the patient is just experiencing fatigue post-op. As nurses, we must acknowledge that proper delirium education through evidence-based teaching is needed so that we are prepared for properly identifying and preventing delirium. Nursing assessment for delirium is important because in healthcare, delirium is known as a medical emergency. The mental status assessment is a brief assessment tool that nurses should be using to assess an older patient's cognitive reasoning at each initial visit. Observing a patient's attention, orientation, language, memory, reasoning, thought process, and thought content is necessary to determine if delirium is present. If you determine that delirium is indeed present, you want to take notice of the time that it starts. Sleep disturbance and insomnia are also key indicators of delirium, so we want to be mindful of this during nighttime hours. Modifying risk factors will be vital in ensuring that a patient recovers from the delirium. However, there are a lot of factors that can be contributing, so we must be critical in assessing all subjective and objective data. Modification of those risk factors can be as simple as creating an environment that is quiet, opening blinds, having the patient place hearing aids, or ensuring that a patient has family members present for visitation regularly. Modification can also be tricky because the contributing factor could be due to pain or infection such as UTI. Ensure that you are identifying what is causing pain so that it can be reported to the physician and treated. The type of delirium assessed, as well as the duration of delirium, should all be included in documentation thoroughly, as well as in your report given to the interdisciplinary team. Documentation should always be concise and thorough, because if the patient has an extended hospital stay, we want to ensure that the delirium is resolved and does not reoccur. Documentation stating the identified precipitating and predisposing factor will make the next healthcare provider aware, ensuring that the transfer of care will continue to be therapeutically concise. Next, we will discuss the types of standardized assessment tools specifically tailored to delirium. The Geriatric Assessment Med Guide is useful for patients who are more susceptible to falling. These patients include those who are frail or those who may suffer from stroke symptoms or hip problems. The 3-minute diagnostic confusion assessment is perfect for assessing delirium because it assesses the onset and the thought process of the patient. If a patient scores at all, they are automatically considered to be presenting delirium symptoms. The Informant Questionnaire on Cognitive Decline in Elderly short form is a screening tool that is designed to determine if a patient experiencing delirium also has dementia. If the patient scores at least a 3.6, they are experiencing dementia-like symptoms. The CARTS Index of Independence Basic Activities of Daily Living tool is a great assessment for older patients who have scheduled procedures such as hip or major cardiac surgery. It is ideal that this screening take place at least 1 month prior to surgery so that a plan can be established to manage the medications as well as post-operative and discharge planning. Scoring is used to determine the functional ability of bathing, dressing, toileting, transferring, continence, and feeding. If the patient has a score below a 3, they are considered to have functional impairment.
Interventions for management, treatment, and prevention of delirium. Initially, you want to eliminate precipitating factors. Research has shown that the onset of delirium acutely can be present in the hospitalized patient within the first to 3 days of hospital admission, and this is the greatest time to have an impact on preventing delirium. Research has shown that no single one intervention is proven effective in preventing delirium. So, using interventions together is proven the most effective. Having a geriatrician consulted in the patient's care has proven to have a 54% decrease in delirium post-operatively. You need to identify and manage factors that can be reversed. Also, having your patient involved in an elder life hospital program can promote independence for ADLs. This can include the use of occupational therapy consultations to support ADLs while in the hospital and promote levels of function in the hospital that the patient would normally use at baseline. Reorientation was proven to effectively reduce delirium in the hospital setting. Many of these are prevention for environmental factors, such as opening the blinds to the patient's rooms and bringing a few of the patient's home possessions to the rooms. You could also declutter the room and use music therapy at least 4 times a day. Caregiver involvement and education of the caregiver has proven effective according to research. Consistency in patient care involves the caregiver. Orientation from the transfer from home to the hospital or from the skilled nursing facility to the hospital with the caregiver involved is proven effective. Pharmacological interventions can be used, and the most used is haloperidol.
Nurses work hands-on with the patient more than any other member of the healthcare team. Because of this, we must understand that we will more than likely be the healthcare provider who is present when an older patient experiences delirium-like symptoms. The prevalence of delirium is high in patients who are older and hospitalized, so we must always be on the lookout. In order to be proactive in prevention, we must become educated on the proper ways to do so. In the article entitled Why We Must Prevent and Appropriately Manage Delirium, written by Dr. Connell, Dr. Dugan, and Dr. Wilson, they identify that a barrier contributing to mitigating delirium is lack of recognition of delirium by nurses. This lack of recognition is due to lack of training. Another barrier contributing to delay in mitigation of delirium is strict visitation policies, as well as hospital noise and lighting. In this article, Dr. Connell, Dr. Dugan, and Dr. Wilson discussed that proposed geriatric units should be considered to incorporate more therapeutic environments to eliminate environmental-induced triggers.
This presentation was put together by Allison, Hannah, and Brittany. We hope you've enjoyed our presentation on delirium and that your patients can benefit from the interventions we have discussed. Thank you very much.